today's DCRI Research Conference. We have the pleasure of having Deborah Fisher here. She joined the DCRI earlier this year, although she's been at Duke for a while. She's an associate professor of medicine in the Division of Gastroenterology, and she's the newly appointed associate director of gastroenterology research here at the DCRI, working with Andrew Muir and others. She's also a practicing gastroenterologist, a staff gastroenterologist at the Durham VA Medical Center. She completed her undergraduate and medical degrees at Vanderbilt University, and then did her residency in internal medicine at the University of Virginia prior to coming here to Duke for a GI fellowship, where she also completed a master's in health services and clinical research. She's built a very robust research program focusing on outcomes and health services research in gastroenterology, with a clinical focus on colorectal cancer screening and surveillance, some of which we'll hear about today. Her work has been recognized by several research awards and is funded both by the NIH and the VA. In addition, she serves on a variety of national committees and is a key member of various Duke GI training programs. She's served on national quality of care committees and has been part of a variety of guideline development processes, and then subsequent evaluation of clinical care and outcomes. So please join me in welcoming Dr. Fisher.
Thank you. Thank you very much. Hopefully everybody's got their code. We'll get started. We got a little bit of who I am and why I'm here. We'll get back to that. I'm going to give a little context to this question, because usually when I'm giving this talk, it's to a group of gastroenterologists or cancer researchers, and this is going to be a more varied group, so a little more background than maybe I'd sometimes give, including what the guidelines are, and then look at what the real-world U.S. colonoscopy use is for screening and surveillance. We're not going to be talking about other modalities of screening for this talk. And then figure out what explains this overuse and underuse, or how can we study it, or what do we know so far, what do we need to know, and then where would we potentially go to make the use, optimize it, make it more rational, make it high-value care in the lingo. So some of the advantages of speaking today is that, as it was said, I'm very new. I moved into my office at the beginning of February. So this is a great chance for me to meet more people to meet me, people who aren't able to be here to look me up and listen to me talk or ramble on about one of my favorite topics, colorectal cancer screening and surveillance. As many of you know, I've been running around doing meet and greet visits, and I really appreciate all of you that I've been meeting and greeting who came to hear me today. And also, in case you didn't know, March is Colon Cancer Awareness Month. Our color is blue, which was extremely helpful when Duke GI went all out for Dress in Blue Day, Friday, March 4th, because as I told them all, they have no excuse for not having blue. And if they root for the team down the road, it's still blue. Put it on, wear it, take a picture. So this is a collage of lots of my colleagues. Oops, you might put that back on. You might recognize a few. Ziad Jalad's here. Of course, Andrew Muir is in several of these. I went a little too far and had blue hair at one point. We have these cool T-shirts at the VA that we did a couple years ago. So it was great. We had everybody from administrative staff to the research labs to the clinical areas, endoscopy areas, in all our different places. This is from one of the walks we're doing. There was Get Your Rear in Gear in Raleigh. And there's Crush Colon Cancer, which is the Duke Cancer Center one on March 19th. So many activities. And the only drawback to talking today, besides the fact I think I had about 3 weeks notice to put the talk together, is it's my birthday, which isn't a bad thing, but I have to say I don't think I've ever given a talk on my birthday before. So this is a first, but I found a nice picture with blue candles. So this is fun. So again, who am I? Again, I'm a gastroenterologist. I'm a researcher. I've been doing outcomes research at the VA for 13 plus years, and I'm here to help really lead the building of a GI outcomes research program at DCRI. Oh, you're so sweet. I feel the love. I love this place. That's very nice. Thank you so much. And I do want to make it clear that while I'm talking about colorectal cancer related topics today, in part because if you're going to put a talk together on shorter notice, you're going to do it on something that you already know a lot about. the GI outcomes research program that we're building is in absolutely no way limited to colorectal cancer or to colonoscopy. I mean, it's really open. It's just we're really trying to have the incredible resources and environment of DCRI that's been so successful with our liver research to do some work in gastroenterology outside of liver. So pancreas, intestinal, all kinds of things. So I just really wanted to make that clear. And then before I dove into the rest of the talk. And one other, as I said, we're wide open. So I'm on the 8th floor. Many of you, as I said, I've seen or I've scheduled to see. I, would be happy for you to come see me. And I'm also very interested in social media. I'm the social and digital media director for GI, which sounds important, but probably isn't quite that important. I think it reflects my enthusiasm more than anything else. But I am on Twitter under my personal account and also the GI account. So please, if you are on Twitter, feel free to follow both. We'll be doing a tweet chat with AGA and Everyday Health a week from today on colon cancer awareness. So I'm the expert for the American Gastroenterological Association, and Everyday Health will be posting the questions. So if you 1 o'clock happen to be on Twitter, you can join that. The hashtag's Health Talk. All right, so now we'll dive into colorectal cancer. And as I said, I'm giving a little more background than I would for some audiences, but just want to make sure everybody realizes that it's very common, third leading cause of cancer death. This is third leading cause for men and women. Actually, if you combine, it's really the second leading cause, because number 1 for everybody is unfortunately lung cancer. Number 2 for women is breast, and number 2 for men is prostate. But when you combine the combination, the total number of men and women with colorectal cancer is higher, or who die from it is higher than either one of those numbers. So it's really, depending on how you look at it, at least the second leading cause of death overall. People have about a 5% lifetime risk. So, it's definitely prevalent enough to screen for it, but we'll put this in some perspective later on. So again, around 135,000 new cases, around 50,000 deaths a year. This has been fairly stable. The deaths maybe come down a little bit. We still, unfortunately, have a substantial portion of people that are diagnosed with late-stage disease, and the 5-year survival rates are very much linked to your stage of diagnosis. So excellent 5-year survival rates, probably even higher than 90% for local disease. If you've had some regional spread, it's not quite as good, but it's really quite dismal for distal disease. And again, we talk a lot about family history, and that's important, but just to emphasize, the vast majority of people diagnosed with colorectal cancer don't have any family history. So you can't be thinking, well, gosh, nobody in my family has it, I'm good. 65 to 85% of colon cancers are for people who were just average risk for it. Then family history, 10 to 30%. And then you have some hereditary syndromes. Of the hereditary syndromes, Lynch syndrome is the most common, but these are far less common, and these really have different screening and surveillance guidelines. So we won't be talking about those as much. So again, your lifetime risk is 5%. Age is the most important risk factor, and that's why that's one of the main screening criterion if you're 50 or older. Almost half the people affected will die of the disease, so it's very important. But you still have to remember this last point. 5% lifetime risk means that 95% of the people aren't going to get cancer. And so they're not going to directly benefit from your screening because they were never destined to get cancer anyway. And I think this is important because up until fairly recently, I've been looking at overuse in medical services for a little while. And at the beginning, it was very hard to convince anybody that overuse was even a problem. Well, as long as they're getting what they need, who cares if they get a little too much, was really the sense, particularly in something like screening. And that, I think, is part of the U.S. culture, because if you go to Europe, they have a very different culture for population screening. Avoiding risk is their number one priority, whereas I think in the U.S., a lot of times the number one priority is not missing any cancers. So it's a very cultural thing, but I think, as we've looked at different models and, as high value cares comes up more and more, when people are like, wow, we're spending a lot of money, what are we getting for it? I think there's been a little bit more appreciation that overuse is not a benign thing. You really have to balance both. So you have to remember, as you're doing all this, up to 95% of the people are not going to benefit from the screening. We're not talking about people who have GI symptoms and need to have an evaluation of those. These are people who average risk, no family history, no symptoms, they're 50 or older, and they need to be screened. So again, of the cancers we screen, I would argue colorectal cancer has the best evidence that it works, that it reduces cancer death, and there's some reasonable evidence that you can even reduce cancer incidence. That's less rigorous data. Those aren't randomized controlled trials like the reduction in cancer death, but it's really, compared to breast and prostate and some of the other things that we screen for, has some of the best data that it's doing what we want it to do. And there were long-standing concerns about underuse because, and I think there are a lot of reasons. One, this might be a little bit more of an embarrassing topic, change in stool habits, procedures involving stool, procedures involving your bottom, so there might be, more reluctance to talk about it. And also because it affects everybody. I mean, there's really no demographic that it's not affecting once you get to age 50 and above. You didn't have, your pink month where this is, kind of a women's issue, for breast cancer. I mean, well, it's men and women, which you think in some ways would make it more important, but it's hard to find a really active group because it affects everyone, ironically, I think. And also worth noting, so because of this long-standing concerns of underuse, there are the National Colorectal Cancer Roundtable has this goal, 80% screening of average risk populations by 2018. And some health groups, like the VA, has reached the 80%. Most haven't. So the original government goal was to reach 50%, and we're probably around 60-65% now. So we still have a little ways to go. And the other thing to keep in the back of your mind is these numbers usually are based on HEDIS measures. The VA has their performance measure, they have surveys. A lot of times, while they focus on the definitions of average risk screening, they don't necessarily exclude people who are higher than average risk, and they don't track higher than average risk screening or surveillance. So basically they're saying in this population of people, say 50 to 75, how many have had a colonoscopy within the last 10 years, a stool test within the past year, a sigmoidoscopy within the last 5 years, et cetera. So they're just kind of looking at testing status. And the fact that some of those people might have had a colonoscopy because they had a strong family history or they had a recent GI bleed or something else was going on, it isn't really accounted for in these quality measures. So it's not exactly average risk screening. And here's something else I like to bring up, because as a gastroenterologist, we like to say colonoscopy is what has reduced the death from cancer. We do colonoscopies. Medicare started to pay for it in 2002. Other payers followed suit, and this is why cancer has gone down. But as my colleague at UNC, Bob Sandler, showed in a commentary a couple years ago, it was going down anyway. And it's a little hard to argue that this curve took the slope change to be more steep after colonoscopy started getting paid for. So there's some environmental things that are going on that cancer death has been going down for actually quite some time. Before we did the fecal occult blood test randomized controlled trials, before we decided colonoscopy should be used for primary screening, before people started paying for it. So this, again, I like to keep a little bit of a balanced talk, because sometimes people get so worked up about the underuse, why is overuse even a problem? I think we have to keep it all in perspective. So just for folks who aren't familiar with the difference between screening and surveillance, I want to make sure we're all on the same page. So screening we use in an average risk population to figure out who's higher risk and who's not. Then once you've figured out a group of people are higher risk, surveillance is their ongoing follow-up. So for example, in the case of colorectal cancer, once you had that initial testing and you've diagnosed somebody with adenomatous polyps, the type of polyps that are potential for precancer, then they're under a surveillance program where we do colonoscopy more frequently, for example, every 5 years, every 3 years, instead of every 10 years. All right, so the guidelines for this have, in some ways they've changed, in some ways they haven't. No polyps, that first line is essentially screening. You don't have anything, and your next colonoscopy is in 10 years. And that's been the recommendation since about 2000. Basically, since we said, hey, do a colonoscopy for screening and not just use it as a tool for high-risk people or for diagnostic testing. And then over the years, if anything, if you could just look at the trends, if anything, we've spread the intervals out. We've realized that we don't need to follow the people as frequently, and we've spread some intervals out. And I mean, way back, people with the National Polyp Study was a randomized trial of every year colonoscopy versus every 3 years. So we used to really go crazy over polyps. In some ways, I would say we still do. You don't need an annual colonoscopy, and you don't need one every 2 years, and you may not even need one every 3 years if you only have some lower risk. And so just because this comes up later in some of the research stuff, if you have 1 or 2 small being less than a centimeter, you're in the low risk category. So you can be seen every 5 or maybe even 5 to 10. But if you tell a doctor 5 to 10, they're going to do 5. And then it's if you have more, 3 or more, or they're larger, or in histology, they have some more advanced features, then these are the higher risk folks that we need to see every 3 years. And this is not talking about the people who've been diagnosed with cancer, had surgery for cure. We're not going to talk about them. And this also, these intervals assume that the colon was clean enough to see what you needed to see. Notice this says adequate, not perfect. That comes up later. That you saw the entire colon, so you got to the cecum. That if you saw polyps, you removed them, so they're not still there. That you didn't have some large thing you had to take out lots of little pieces, because that's a separate situation. And again, that the person doesn't have any family history. So, overuse of colonoscopy for screening. And so what we mean by overuse is you are average risk. You have a colonoscopy that doesn't show any of the adenomatous polyps. You should, according to the guidelines, not need a colonoscopy for 10 years, and your doctors tell you to come back sooner for screening, not for symptoms. And so there were some surveys, and they looked at various groups, primary care, surgery, GI, and the doctors, according to the surveys, so sometimes they'd have like a vignette. You have a patient with this scenario, what would you tell them to do? So 20 to 64% of the time, depending on who they were asking, how they were asking it, they would say, yeah, I would tell them to come in sooner than 10 years. And then they also did some studies where they looked in medical records, and they said, you know, what's being documented for recommended follow-up? And the same story. Now with adenomas, the adenomatous polyp follow-up, same thing, even gastroenterologists who should know better, we had groups saying, you know, you needed to come in sooner than what that big chart of guidelines said. So this has been going on a while. And this goes back to the why more is not better. And these are some of my arguments. So one, this is opportunity loss for the patient. Colonoscopy, you know, is a fairly big deal. I mean, there's certainly bigger deals out there, but you know, you have to take a day off, you have to find a driver, you have to schedule, you feel kind of, you know, really don't feel yourself for almost 2 days afterwards, just because sedation, I think, has a bigger hangover than we give it credit for. You know, it's a big deal. And then some people have to really get themselves psyched up to do it. It can be a big deal that way. So it might be that, you know, if you're focusing on getting all these more frequent colonoscopies, there's some other part of your care, you're not making some other appointment. So that's a possibility. Every colonoscopy has risk. I mean, we're lucky, it's a low risk procedure, but you know, 1 in 1,000 times we're going to make a hole in your colon and you might end up with a colostomy. You know, 1 in 200, 500 times you're going to have a major bleed that has you coming back into the hospital, getting a transfusion or surgery or another procedure. There's a finite risk of death. I mean, it's low. It's 1 in 5,000 to 10,000, depending on, you know, a lot of other factors, but it's not 0. So if you're coming in sooner than you need, you're putting yourself up for risk and you're not really getting any more benefit. Something that's come up more recently is access to colonoscopy. So even at Duke, we're running about a 6-month wait list. If people who don't need the colonoscopy are taking the appointment slots, the people who do need it, they've never had one, they're higher risk, they're due, and you're not, you don't have it. And as you look on a national level, we do not have the capacity to perform colonoscopy on everybody who would be eligible for screening if this is what we used as our only screening tool, and to do the follow-up for people that we would find polyps, et cetera. So we don't have the resources locally, nationally. Being in the VA all those years, that was very much a resource issue. And then it's opportunity loss for the system, because it really is a closed system. You spend a lot of money on colonoscopies people don't need, well, that's money you're not spending on something else. So why don't doctors do what they're supposed to do? Well, there's many reasons. This is based on a couple conceptual models, but I think it's pretty easy to follow even without going into the theory. We've got all these buckets of things. So, ultimately you have what they intend to do and then what they recommend. So they need to know the guidelines. If they're not even aware a guideline exists, they're not going to be familiar with it, they're not going to know it. Relatively straightforward. They might completely disagree with the guidelines. They might think guidelines themselves are, incorrect, waste of time, bean counters, what have you. It might be that their patients are used to getting a colonoscopy every 3 years, whether they need it or not, and are demanding it. Or that they're referring patterns, or that everybody else in their practice does that. And gosh, my RVUs won't look as good because, what have you. So these are called subjective norms. That's with the people around you who influence your behavior. And then there's, various external factors. So when these initial surveys came up, there was a bit cynical, but you can't blame people. They're like, well, fee for service, you get paid for colonoscopy. You do more colonoscopy, you'll get paid more. Of course they're doing it more frequently than they need to. So there was a lot of thought that this was really just all about billing, collecting, and that was it more than anything else. So, one of the reasons why looking at the VA was very compelling for this is a salaried physicians. I mean, you, as a VA gastroenterologist, I don't get any more or any less for how many colonoscopies I do in general or for a particular person. And in fact, you could imagine there might even be a disincentive to do extra colonoscopies for various reasons. So, or are the concerns more, universal things that are not practice-based, don't agree, or local pressures, or nobody knows what the guidelines are supposed to be, or other considerations. So we did an observational study of 25 representative VAs, and by representative, we looked at 4 different regions. We looked at resource levels. There's a VA measure called complexity score, but basically, very high resource ones like the Durham VA, lower resource ones. The lowest category generally didn't offer colonoscopies, so that really they weren't included. We also looked at non-academically affiliated and academically affiliated. So we looked at all these different factors and we did it in the proportion that they exist in the VA because we wanted to be able to paint an accurate VA picture. We're looking at 25. There's probably over 100 places that offer colonoscopy at the VA. So we wanted this 25 to be representative of what's going on. So again, and then another study we did was a survey. Now the survey was just of the VA paid gastroenterologists. And again, this was looking, so we had 2 studies. One, we wanted to see, what was going on based on medical record documentation, administrative data, and the other one, what are people thinking who work in the VA system? So let's see. So the response rate for the survey was about 40%, which for a doctor's survey isn't bad. There were about 500 at the time, VA paid gastroenterologists, and about 200 of them. Most of them had been in practice for a while, but full range. Slightly more female representation than gastroenterologists in general. It's about 85% male, 15% female, but I don't know for the VA, so I'm not sure what the ratio is within the VA. And basically, we had a lot of people who, everybody said they were familiar, but as far as knowledge, a lot of knowledge, but there were a few places where people said, oh, you're supposed to come back a little sooner. And then there were a few places where they said, oh, you're really supposed to come back a little later. So there were a few knowledge gaps based on this survey, which had the patient vignettes. And then when we asked, what do you actually do, not what would you, not what does the guidelines say you should do, but what do you do? Again, we had some folks saying they would bring people back earlier, and then we had, some folks saying they'd bring people back a little later. So what we concluded was that, and then we looked at some other factors, and we found that for the multiple adenomas where people potentially would have brought people back later than the guidelines, this was linked to people thinking that guidelines are used as a discipline tool, that they were less likely to agree it was a discipline tool. They were less likely to agree that it affected physician reimbursement, which of course we weren't reimbursed for any of these in this setting. And they were less likely to agree that if you did an earlier colonoscopy, there was some additional benefit that wasn't being captured or represented in the guidelines. And then the folks who had the low-risk people that they would bring back sooner than necessary, they were less likely to agree that guidelines were a convenient source of advice or that the clinical research justified the current recommendations. And they were more likely to agree that if you followed the guidelines, you had an increased risk of missing cancer. That they didn't apply to many of their patients, and that there were some guidelines. So it kind of made sense. We got a sense perhaps there's some other things going on here. For fear of missing cancer, don't completely agree with the guidelines. And these were people who gave the right answer. So they know what the guidelines are, but they don't agree with them because they said they would do something else. And these were some of the other questions in the survey. So some potential knowledge gaps, some factors other than knowledge might be influencing these recommendations, and there was some potential for overuse and underuse. And of course this was, self-report, it was anonymous, and this was only gastroenterologists who perform probably close to 80% of colonoscopies in the VA, but not all of them. So then we had the other study, this was medical records. So what we said is look, we kind of have this idea of what they say they do. What are they actually doing? Because there are many studies that show that what doctors say they do for screening isn't what they actually do. And that's particularly true in underuse. So if you ask doctor, how often, what percentage of your patient panel is up to date on their breast cancer screening, they'll say 98%. You go through the records and it's 75%. So they tend to overestimate these things. So self-report, it has some limitations, and we wanted to look and see what was in the record. And we also thought in the record, because the first one was anonymous, we couldn't really say, well, gosh, doctors in this type of VA or in this part of the country are doing X, Y, and Z. So if we did it through the medical records, we'd have a little bit more information about what they actually do with actual patients. Are there other trends we should be aware of? So we wanted people who, this was their first colonoscopy, because really the guidelines are the clearest there. Once you're on colonoscopy number 2 or 3, it gets fuzzier and fuzzier because you've got more and more data inputting, and we really aren't as sure of what is the right thing. So we wanted it to be pretty clear what was following the guideline, what wasn't, try and remove others. So we took the younger people in the screening age. We also wanted to avoid, well, what if they're getting care, Medicare? It tends to confuse the issue. So we took the younger ones. We took out high-risk people, so anyone who'd already had cancer, had inflammatory bowel disease, if they'd had any colonoscopy for at least 10 years prior. And we only took facilities that performed at least 500 colonoscopies a year and that we could access their notes. So we went through the sampling. We had about 100 people at each facility. We oversampled for women and minorities because this is the VA. We wanted to make sure there wasn't anything different. Minorities wasn't a problem. Women is a little bit of a problem because while female patients at the VA is increasing, it's mostly younger patients, not people of the screening ages. So we also did not include in this analysis anyone who didn't have a recommendation, that they didn't get to the full colonoscopy or it wasn't documented. if their risk category wasn't clear, like whether they were lower risk or higher risk, if their bowel preparation quality was not adequate or missing, and if they didn't have a pathology report, because then again, we wouldn't be able to tell what category they went into, assuming tissue was taken. And also, as I said, if it was incomplete, if the bowel preparation was marked as inadequate, and we finally had 1455 unique patients, and we had only one colonoscopy per patient. So the majority of people had normal colonoscopies. Of the people who had polyps, it was, mostly hyperplastic or the low risk. We have a relatively small group with high risk, and this is what you'd expect. Of course, there were a lot more men, even with the oversampling. Most of these colonoscopies were for screening. Some were for diagnostic because it was a first-time colonoscopy, and the people were pretty healthy. And then again, here we had about 58% of the colonoscopies were done by gastroenterologists. A fair number were done by surgeons, some by people in internal medicine that weren't listed as a gastroenterology specialist. And again, mostly male endoscopists. And we had, as I said, non-academic and academic VAs. We had different resource levels, so kind of really big places, not quite so big places, and places from all over the country. And this I color-coded, so this is just the raw guideline adherence across all categories, whether somebody had whatever polyp or had screening, and over the 25, anonymous. And the people who were at least 80% of their patients got the guideline adherent recommendation are in blue, and the ones that who 90% or more of the patients are in green. So at these facilities, at the facility level, there people doing endoscopy were following the guidelines a lot of the time, 80-90%. And then in yellow, I've got the folks where it was below 40% of the time their patients were getting the correct recommendation, and in red below 30% of the time. So I think, for folks who don't do VA research, there's sometimes this sense of, the VA is this one big homogenous thing, and what happens, happens. And it's not true at all. And it's including, following the guidelines and quality measures. There are places that are always following the guidelines. There are places that are almost never following the guidelines. And then everything in between. So huge variation. Overall, these again are the unadjusted. So overall, it was 63%. And this was really helped by the fact that in the screening situation, 72% of the time they got the 10-year interval. And because the majority of cases were normal colonoscopy, this helped. But less, 50% plus or minus in the polyp scenarios. And 95% of the recommendations were for a shorter interval. So there were a few, if you remember in the survey, it looked like, well, there might be a lot of people recommending longer intervals. When you looked at what's actually happening, almost all the time, if they didn't follow the guidelines, it was for shorter. So a potential for overuse. And this is just another way of looking at it, where this kind of gave how much were they getting people earlier. And as you can see, there's kind of a clustering around 5 years. So while we got almost every number from 1 to 9 when it wasn't 10, most of the people, if they didn't say 10, they said 5. I mean, there are a few people saying 8 and 7 and being creative, I suppose. And the same thing with hyperplastic. The right answer is 10, but the second highest number was 5. So that was also pretty common. And that's just another way of looking at the information. And well, what did we find were the important factors? Because that's really what we wanted. It's like, okay, there's a problem. We've established there's a problem, but to do something about it, we need to get some sense of what are potential targets. So we found 3 big things that were associated with not adhering to the guidelines. So one, again, and this was suggested in the unweighted analysis, it depended on what your risk level was. If you had a normal colonoscopy, not so bad. If you had hyperplastic polyps or the high-risk polyps, it was actually it was a much higher risk. So people were not going against guidelines for everything. Some patient scenarios were being more affected than others. We also found, if you remember, all the people who had an inadequate PrEP were excluded. But we definitely found that when it was labeled as fair, people hedged. So the guidelines say adequate. But if it wasn't good or excellent, a lot of people felt uncomfortable. And there was a pretty high chance that you would, there was odds of 4.3, that you would not give the guideline recommendation. And there's been a lot written about this. And they've even looked at adequate PrEPs to see whether you could see important findings. And it does appear that you can. So, if it's fair, you can still do 10 years. It doesn't have to be absolutely perfect. But you had a lot of people that, I think it goes back to, concerns of missing cancer. If it was fair, like not so bad that you just said, okay, this was awful, you need to reschedule in the next few months, they hedged. And there's some other data that shows if you do miss a cancer, not necessarily for PrEP, but for some reason, if you do miss an important finding, the cancer is diagnosed within 3 years. So actually, bringing people back in 5 years instead of 10 really doesn't even accomplish what you want to accomplish. So I think the bottom line for people who do endoscopy is if you're not comfortable with the PrEP, you need to stop and you need to bring the patient back for another procedure. And if you went through it like I was comfortable that I saw, then you need to follow the guidelines, because bringing them back sooner isn't accomplishing anything. And then finally, there was definitely a geographic, with the Northeast being a big user compared to Midwest. South and West, really no difference. And this has been shown in other studies, not even just of colonoscopy, but utilization in general tends to be higher in that part of the country. So then we said, okay, this is what they wrote in the chart, come get. Did they get these? Maybe it doesn't matter because maybe the veterans just come when they come and they're late anyway and you tell them to come early and then they come on time and maybe this is a good thing. So we went ahead, at this point, we had 6 years of follow-up data. So what happened? And basically we had, so the blue is on time. So all this yellow is early. And we had a fair amount, over 30% of the low-risk people with normal colonoscopies, people with hyperplastic polyps, people with those two groups that came in too soon. Where they were told, and it was linked to being told to come in too soon. So it does seem that if you tell them to come in too soon, they're more likely to come in too soon. So it's important what you tell people to do. But was a little surprising and very concerning was that the highest risk people were actually at 6 years. So these people were due at 5 years, at 3 years, at 6 years, 40%. That was it. So we were missing half the people hadn't had their colonoscopy and they were 3 years late, and they're the higher risk. So clearly this is not just a story of people coming in too soon. These highest risk people are not being followed adequately. So we had a couple questions after this. All right, well, what's happening outside the VA? Is there some way we can see whether some of these trends we saw, fear of missing cancer, and some of these attitudes and trends actually match what people do? Because our survey was anonymous, so we couldn't link it to what was in the record. What data source could we have to do this? So we have this study, which uses the CORI database, which unfortunately is no longer available as of 2015. So NIH did not fund its third continuing renewal, which I think is kind of sad. But anyway, it's a database that has a huge number of reports. In 1 year, they get more than 250,000 reports from 70 practice sites in 24 states. They have hospitals, ambulatory settings, private practice, university, about 5 VAs. So there is some VA in here, but it's not very much. 375 participating endoscopists at the time we started the study. So here was a group that we could look at their recommendations that they had as part of the medical record, and we also knew who they were so we could send them surveys. And we took people who did at least one screening colonoscopy in the past 18 months, because some of the folks in this database might hardly ever do a screening colonoscopy, and there was no point in sending them a survey. And then we also took people who'd done any procedure in the last 6 months, because while some practices, their use of CORI would come and go, if an individual physician at a practice left, CORI wouldn't necessarily know about it. So you didn't want to be sending a survey to somebody who'd left the practice. We just want to make sure they'd done something in the last 6 months. So they were likely to still be there. And again, the CORI included medical history, indication for procedure, some pre-procedure things like ASA classification. The important things were procedure details, exam findings, and this follow-up recommendation. And this just gives an idea of what things we were asking in the survey. So again, there were some demographics, but there were some knowledge questions, and there were some attitude questions, and there were external factors, variety of questions. And this was based on the survey we'd used before. We eliminated the familiarity question because everybody said they were familiar. So a little under 200 met the inclusion criteria, which admittedly was lower than what we'd expected. They were from 14 states. They performed over 14,000 screening colonoscopies in the prior 2 years. And we had, again, about a 42% completion rate. Mostly gastroenterologists, but other specialties, and then a variety of settings, academic, non-academic, large, small community practice. And in the vignettes, so for this we were just asking about screening and screening with a family history because we didn't have the data to do anything that involved polyps. You need to have the histology data, and that was not available. So this was just looking at screening. So from the survey, just looking at it, the vast majority of people gave the right answer. So there was no knowledge gap, at least for screening and screening with family history. But we also had a majority of people that agreed that it's difficult to know the guidelines because we have so many and there's so much data. And we had a little over half that agreed there were benefits to repeat colonoscopy that weren't captured in guidelines. So again, whether this is, the guidelines aren't good enough to catch cancer, or we're reassuring people, or there's something else going on, they're attributing some other benefit that is not included in the guideline. So this, we're still actually analyzing the data, so this is fairly fresh, but just to give some findings so far. So we found there's this, 42% of the people, when you're talking average risk and family history, so 42% of the physicians followed the guidelines in the medical record more than 90% or more of the time. And then you had slightly lower number, 90% of the time, when there was a family history involved. And then you had this group of 12% that almost never. And you can see, the distribution. So again, there's a big variation. And what was interesting is the folks who followed one guideline didn't necessarily follow the other, which also went along with our other, with the polyps, the same people, you'd have folks that, 72% of the time if it was a normal colonoscopy, they'd follow the guideline, but then for hyperplastic polyps, it was down to 40-something. So again, it depended on the clinical scenario how well people follow the guidelines. So that theme, and it didn't correlate in this study at all. We were able to look at some items for response bias since we had information on everybody, and we found that adherence didn't vary by where you were, so the different practice types. It didn't vary by what type of colonoscopies you tended to do. Screening, surveillance, diagnostic, but the folks who didn't respond to the survey tended to have higher volume, which makes sense. They're too busy doing colonoscopies to do my survey. I understand, it happens. But we did find that adherence to the guidelines, among the people who did fill out the survey, adherence was not related to your volume, at least for average risk people, and maybe was related a little bit in the scenario for family history. So volume probably wasn't a huge marker of much of anything. So the fact that it was imbalanced perhaps wasn't too important. So then we have all these data, and unfortunately not a huge number of people. And those of you who do a lot of modeling and are on the methodologic side of it are thinking, you had, you started off with less than 200, you got a 42% response rate, we got 80 people, you're not going to go crazy with, this survey and all this data you have, and like, come on, what are you doing? So what we looked at was the percent deviance. We have all this variability. What sets of data helped explain this variability? So user just means you plugged in the ID. So that doesn't tell you anything about the person. The patient data explained almost nothing, 3%, which makes sense because it's really not so much patient-driven, like, women are being treated differently than men or something like that. So if you took user characteristics, so this is, all the physicians, user was survey, but anyway, all the characteristics of the physician, so their specialty and where they practiced and their how many years out and just everything about them, and you added the patient data, you explained almost half the variability. And then as you added practice characteristics, it kind of went down. But the questionnaire really didn't explain very much, like 15% of the variability. So it really didn't tell us a whole lot. And actually, and as I said, we're still analyzing this. So the main model we're going to present for the manuscript is going to be really using the Cori data, not using the questionnaire. And we're going to present that as well, but kind of as a secondary thing. Because one, it's a smaller sample since we had 42% response rate. And two, it doesn't seem to explain very much of what's going on. We got this groups of people that are always following them, groups of people that never follow the guidelines, smattering in between. We want to figure out targets for intervention. And honestly, the questionnaire didn't really point us in any good direction. And this is the story, which is very similar for the family history scenario. And we looked at some quality markers to see do people who have high quality colonoscopy follow the guidelines, if you consider following the guidelines a quality metric. And maybe the LGPDR is large polyp detection rate, which is a marker for adenoma detection rate. And so maybe, mostly just with patients who had a family history. Otherwise, none of the markers seem to go together. We again see New York not adhering very much, and Tennessee, which is a little strange. So definitely some geographic variation. So putting this all together, what do we know or think we know at this point? So we've identified maybe some small knowledge gaps, but I really don't think that's the big story. I really don't think beating people over the head with, you don't know the guidelines, here are the guidelines, pop-ups on your EHR, guidelines, is going to accomplish anything. Because there's some issues with agreement with the guidelines. It seems that your local practice patterns are very, very important. I think that's reflected in regional variation. I think that helps to explain why VA physicians in the Northeast are doing so many more colonoscopies or recommending so many more than other parts of the country. They're not getting paid anymore, but if they're surrounded by other people who are doing a lot more colonoscopies, then that local practice has a lot of influence, even if the patients or referring physicians don't have expectations that would be driving that. Bowel prep is clearly an issue in that if people aren't feeling super comfortable, then they're going to hedge on the side of more frequent colonoscopies. So anything that can be done to improve the bowel preps going in will improve how appropriately you're using it. And then it varies by clinical risk. So, screening colonoscopy versus polyp follow-up, it's not all the same thing. Cori, we're still analyzing, but it does seem that practice location and clinical risk, again, are driving some of these things. And again, the agreement attitudes doesn't seem to be as important. So it's probably, again, more about local practices and clinical risk of patients and things like that. So again, maybe less about what you think of the guidelines or particular patient, more about these practice patterns, your confidence in the main examination, prep falls into that, risk categories. So some future directions. So I think this is something that would work with a system level intervention, because what we really want to do is make the environment more conducive to following the guidelines. Whether that's setting up the default for the guidelines, and then you have to, if there is a particular reason you want to bring someone back sooner, that's, the default isn't just whatever you pick, it defaults to, 5 years if that's what the pathology comes back and that's what your guideline is. And if you want 3 years, you have to say why. We need better tracking because clearly, since all these quality measures going back to the beginning when we talked about HEDIS and all that, they're set up that colonoscopy every 10 years. Well, there's this group of people that really should be having it every 3 years, and we're not tracking them. It's not a quality measure. Individual practices and systems and groups might be tracking them, but overall, for example, in the VA system that's had, an electronic health record since the 90s, not tracking them very well because between 3 years when they're due and 6 years, they hardly pick up anyone. So you could say, well, they're just waiting in line for it. They're not waiting in line for 3 years. 1 year I could imagine, but not 3. So we're just losing some folks that we need to follow more closely. And again, anything we can do to increase the confidence in the initial examination, whether it's interventions to improve bowel prep, like doing split preps, which there's a lot of evidence for, and doesn't cost any more than having it all the night before, or if there's other practice improvements. There are some data in the endoscopic literature that certain interventions make people better endoscopists. And then there's another question. There's been a lot of concern about disparities in cancer outcomes that aren't really explained by disparities in screening rates. Maybe it's not the screening rate, maybe it's these high-risk people that are getting lost. If there's some disproportionate number of those people that are in some of the minority groups that are having very poor outcomes, you can imagine if, your healthcare system's set up to send you the reminder, it's been 10 years since your last colonoscopy, as some of these things are, and they're not nuanced for the higher risk people. If you were due at 3 years and you show up at 10 years, biologically, that 7 years is long enough that you could have something really bad when you come in. So that's another question we'd like to explore. So that's what I have. Again, it's Colon Cancer Awareness Month, and here's AGA. I love their banner. One of the things about GI is we have a lot of bad puns. No buts about it. The bottom line, it just goes downhill from there. You don't want to know. But we've got love your colon, check your colon. That's what the little text speak is. And we have some time for questions. Happy to take any questions if anybody has any. I appreciate everyone's attention through this journey through the colon. Yes.
I don't know how often the guidelines change, but I do remember them being very complicated when I had to learn them.
Yeah, they're pretty complicated, which is a disadvantage. Although, like I said, knowledge gaps weren't the biggest problem. I was like way back to the evolution. But one of the points we made is that for a lot of these, the changes recently, like serrated polyps, nobody had ever heard of before, so they didn't touch them, and we didn't study them. But the high-risk people have been 3 years, since 2000, and 5 years since at least 2003. And we didn't ding, if the guidelines said 5 to 10, we accepted everything 5 to 10. So while they do get complicated because there's all these different risk categories, and then there's all these, caveats about bowel prep and extent and completeness and no piecemeal, they really haven't changed in well over a decade. And so I think, again, that's why I don't think knowledge gaps are explaining it. We haven't really found any. I think it's other concerns people have. Now, it could be, some groups got used to doing everybody every 3 years, here, and then they've just been ignoring everything we've been saying for the last 15 years. But they haven't changed as much as you'd expect, but they are definitely complicated.
Been able to identify like the younger providers who are just out of training or more adherent?
There were no difference. Yeah, we looked at that. We looked at that in the CORI, and we also looked at that in the VA because we had when they graduated from medical school, and there were no physician characteristics that were predictive. We didn't have a lot to look at, but we looked at years since medical school graduation. We looked at board certification status. We looked at specialty because some of the surveys had looked like gastroenterologists did a better job than surgeons, but we really didn't find any provider that were just the provider. It really seems more the environment that the provider's in. Yeah.
I think you said that these guidelines really came out from mostly observational studies. Are there any clinical trials actually looking at the screening based on colonoscopy actually had a really significant reduction on cancer?
So for screening, what we have for randomized controlled trials, there's the stool studies we mentioned and the UK FLEX-SIG study, which is an endoscopy study. It's not a colonoscopy study, but the UK FLEX-SIG study, which did show a decrease in cancer deaths with screening. There are 4 randomized controlled trials of colonoscopy ongoing now, including one in the US that's in the VA. The VA one is comparing FIT testing, so the fecal immunochemical testing, to colonoscopy. The European ones, I think, are comparing to no screening, which would not be a study you could do in the US because we recommend screening. So all the data for colonoscopy are really extrapolated. And, there have been a lot of looks at, is colonoscopy really that much better than sigmoidoscopy? Now, there's been a fair amount of data supporting the 10-year interval. While we're not saying colonoscopy is the best test, we really don't have the data to say that. There's a fair amount of data saying that 10 years, that people who've had a normal colonoscopy and then are followed up again, that the protection from cancer lasts like 15 years. So that a 10-year interval is pretty reasonable. So there's been a fair amount of data for that. Some of these other intervals we really don't know, because the only randomized controlled trial looking at intervals for polyps was the National Polyp Study, and that was 1 year versus 3 years. And they didn't find a difference, but those were both probably more frequent than was needed for the majority of patients.
Do you expect anything will change in the sort of growing setting of alternative data models and ACOs?
I think a lot of, as far as intervals, I think people might pay more attention to them. There's already one in the warehouse of quality measures. There's one that if somebody has a normal colonoscopy, you shouldn't bring them back for 10 years. So people are starting to pay attention to these intervals. I think that's one thing. I think for baseline screening, and that wasn't the focus of the talk, but I think people will be looking at less expensive, non-invasive, screening strategies like FIT, stool DNA perhaps, although it's a pretty expensive test because it's $600 retail and $500 to Medicare. But I think people might be looking at strategies that involve less colonoscopy because that means less money.
Great. Well, happy birthday and thank you.
Thank you.
To Cincinnati.